Welcome to the Air Medical Today podcast. My name is Edward Ero, and I am your host for episode 36 on February 19th, 2021. This podcast is part of the Ero Podcast Network, podcasts that inform by focusing on both the news and the people behind the news. With each episode of Air Medical Today, we explore a specific area of the air medical industry and community through the use of interviews. You can find Air Medical Today on the web at airmedtoday.com and on Facebook, Twitter, and LinkedIn. The audio podcast is indexed on iTunes, and the video version is on YouTube. For additional information about the guests on the podcast, I also provide background data on the Air Medical Today website. If you would like to become a sponsor and/or leave feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. Today, I am interviewing Ms. Roxanne Shanks, the CEO of LifeFlight Eagle and the Executive Director of the Association of Critical Care Transport in Kansas City, Missouri. Before we get to the interview, I want to go over some feedback from previous episodes and provide some general updates. As I announced in the last episode, Air Medical Today is also a video podcast now. A big thanks to Michael Christensen, the Executive Director of Air Transport for Sanford Health, and Tom Allenstein, the President and CEO of MedFlight of Ohio and Medcare Ambulance, for being first and second interviews using this new video format. As always, you can listen to the podcast and now watch it on the new Air Medical Today YouTube channel. The link to the channel is on the Air Medical Today website. If you have not listened to past podcasts, please take the time to do so. There's some really interesting information on how programs are reacting and adapting to the COVID-19 pandemic, as well as handling the stress that this has caused for frontline staff. In the last several podcasts, I have been interviewing the leaders of various air medical programs. While there are many similarities, there are some big differences on how these programs are organized and operate. Please tune in to these informative podcasts. I would also like to thank the followers of Air Medical Today on Facebook, LinkedIn, and Twitter. To date, Air Medical Today has 22,380 likes or followers. Thank you very much. It is my pleasure to welcome Roxanne Shanks, the CEO of LifeFlight Eagle and the Executive Director of the Association of Air Medical Transport, to the podcast today. Roxanne has been in her role at LifeFlight Eagle since 2012 and as the leader of ACCT since 2014. Prior to LifeFlight Eagle and ACCT, Roxanne was a service leader with Mosaic Health in St. Joseph, Missouri. Well, good. Welcome to the podcast, Roxanne. It's really great to have you here and nice to connect with you again.
Thank you, Edward. Thanks for having me. It's good to connect with you also.
Yeah. Well, how I like to start these, my thing is always the news. We want to talk about LifeFlight Eagle, but I also like to talk about the people behind the news and some of your background so people understand how you got into the position you're at. And thanks for sharing your CV and bio information. Like I say, every time I do this, I learn things about people that I never knew about. So
I'm sure.
You started your career as a respiratory therapist in 1988. Your undergraduate degree was actually in chemistry in 1992. How did you choose respiratory care, and was that your original plan?
Well, my original plan was actually pre-med, and I had to laugh. I think your last podcast, Tom Allenstein, had the exact same path.
Yes.
I was pre-med at St. Louis University and did actually graduated my chemistry degree and after pursuing that degree and challenging degree, I decided I did not want to spend another 8 to 12 years in school. So during the time I was in college, I was doing respiratory therapy at the hospital on breaks in summer, and I still wanted to do healthcare some form. So that was just a natural path for me. So I went back and did my degree in respiratory and then evolved from there. So that was kind of my path forward.
How did you choose your undergraduate school, St. Louis?
They had an incredible medical school. And so that was kind of where I did my research from. And I wanted to move away from home, go experience a new city. And I lived in a very rural area. And so that was kind of my path. So.
Oh, great. Yeah. Excellent. So you went back and received an associate's degree in respiratory care in 1995. Talk about the respiratory care positions you held at Mosaic Life Care, that's formerly Heartland Health, in St. Joseph, Missouri.
Sure. I really started out in the clinical medical floors doing respiratory care, and then eventually moved into the critical care areas. And eventually I was running the bronchoscopy labs, and that's where I started to look into the management side of it. I had the fortune of working with a leader at the time who recognized some leadership abilities in me and that I liked big business. And so he kind of took me under his wing and taught me the business side of it. And that's when I ended up being the director of the department eventually when he retired. And that's when I went back and got my MBA in management. So
that's how you started in leadership management.
Yes.
Yeah. Interesting. So you talked about your NBA. The titles there were service leader. Is that like a vice president?
It was a vice president role, correct?
Yeah. That was when I was at Duke, it was that way too, as like assistant administrator, associate administrator. Yes. So I think
all organizations have their own names for them.
Right. For sure. Hospitals do that. Usually the VP is more at the corporate level, I think.
Right.
You in 2012, you became service leader of clinical services. Now, what was the difference there? Was that a higher level position than the emergency
it was
services?
Emergency services encompassed emergency department, ambulance services, and trauma services. And then they added clinical services, which was the lab, radiology, and pharmacy. So they really combined two service lines into one and expanded that role. So it really was a promotion, if you look at it in a sense, but it was getting more duties, if you will. So
I'm familiar with that.
Yeah.
We have more departments for you. Yes.
Yes, exactly.
Yeah. Wow. So the big move into the air medical services then was in 2012.
Yes.
And you became the executive director of LifeFlight Eagle in Kansas City. Why the switch from your position at the hospital?
Sure. We had undergone a leadership change at Heartland Health. They had our longtime CEO had left and a new CEO came in. And with any leadership change, there's always a culture change. And I had seen the culture change shifting, and I really was not, it wasn't aligned with what I liked in a culture, to be honest with you. And I was thinking, what would my next career change be, and what did that look like? And I had the opportunity to be introduced and work with Jay Fitch from Fitch Associates in 2005, because we had brought them in to Heartland Health to help assess and run our ambulance service. And so I had been working with Jay for about 7 years. And his partner, Christine Zoller, who runs their air medical division, was looking for a full-time CEO at LifeFlight Eagle, but she wanted someone with a healthcare background that also understood EMS. And so Jay said, you need to talk to Roxanne. She's got both of those and she is looking for a different career. And so I met with Christine and she had the exact same values that Jay did. And I had a lot of respect for them and their company. So I knew it was going to be a good fit, and it has been an incredible career change for me. So
that's very grateful. So Jay was the connection there.
He was. He was.
That's great. Yeah, having full disclosure, I worked with Fitch Associates too, actually on the med-serv side. But got a chance to work both with Jay and Chris too. So great people.
They are.
Let's talk a little bit about LifeFlight Eagle then. Sure. The program actually was the result. It's a consortium. It was a result of a merger of two programs in Kansas City in 1996. Could you talk about the history of the two programs that formed LifeFlight Eagle?
Sure. The Spirit of Kansas City LifeFlight was actually the fifth civilian air medical program in the nation, and it was formed in 1978. And then Research Eagle began in 1985. So the leaders from both of those programs concluded that they could better and more effectively serve the communities by working together. So, the hospitals actually engaged Fitch Associates. They come back into the picture again
Oh,
in 1996, and Christine Zoller actually formed the LifeFlight Eagle. She merged those two programs. And then the hospitals, who were competing hospitals, actually asked Fitch Associates to manage LifeFlight Eagle. So their management company that you mentioned, MedServ Management, has been managing LifeFlight Eagle since 1996.
right.
So that's
Right.
how the formation occurred. And it was formed as a nonprofit at the time, and it had four members, which were Research Medical Center, St. Luke's Hospital, Children's Mercy, and St. Joseph Medical Center were the four at the time.
Are those still the four? Are there other?
They're not actually. Not just a few years later, Research Medical Center was bought out by Health Midwest, I believe, at the time. So they became a for-profit medical center and had to withdraw their membership.
Yes, I think I remember that. Yeah.
And then I believe it was 2016 that St. Joseph's Medical Center was bought by Prime Healthcare, which was a for-profit, and they withdrew their membership. So we now have just two members, which are St. Luke's Hospital and Children's Mercy Hospital.
Yeah. So how is LifeFlight Eagle governed? How many board members are there, and how are they chosen?
We have two board members from each of our member hospitals. They're appointed by their member hospitals, and they're executive level board members. So the CEO and CFO from St. Luke's Hospital sit on our board. And then we have two vice presidents from Children's Mercy that sit on our board. And it just varies, but they may serve on our board for years. It just depends. Our last two board members, we had two board members that had served on our board for well over 12 years, I believe. So, but these four new board members are fairly new to our board. And then we also have a medical control board and an advisory board. We created an advisory board several years ago, and that is members from other tertiary hospitals in Kansas City that are not members of LifeFlight Eagle, but we still, take patients to them. We partner with them on education and different types of things. And so we wanted their involvement and at least input into our organization, and wanted them to be aware of our operations and things that were going on with LifeFlight Eagle. So that involves 8 other hospitals in Kansas City that actually, are involved in our organization, if you will. They just don't have voting rights. So
is it primarily from a clinical standpoint then, you're saying?
Clinical and operational. We provide them operational information as well.
I see.
Yeah.
But so who are those members? Are those clinicians though that are sitting?
No, they're executives from the hospitals as well.
I see. Oh, I didn't realize that.
Yeah.
How often does that group meet?
That advisory board only meets a couple times a year.
Mm-hmm.
It's just, really to touch base and keep them updated on what we're working on and those types of things. And, it could meet more often if they have needs or we have things that come up, but it's really just to stay in touch with them.
So how often does your board meet?
It only meets 3 to 4 times a year, typically. If we have
quarterly
other
type,
yeah, correct. And if we have other needs that arise, we can always have additional meetings, but that's typically what we do.
I see. Are you a board member?
Myself and Chris still serves as the president, and we both are board members. We're just non-voting.
Non-voting. Okay.
Correct.
So talk about your senior leadership team. What positions are there, and is LifeFlight totally independent, or do you rely on any other services from your consortium members?
Sure. I'm extremely blessed. I've got a leadership team that is a diverse group of individuals, extremely talented, and they've all worked for us, a lot of them over the years, as flight nurses, flight paramedics, but they've been moved into leadership roles. We've recruited some from the outside with different backgrounds, such as logistics, marketing, journalism, those types of things. And we have a long tenure of leaders too. Some of them have been with us since the merger of the other programs. And so just very blessed from that standpoint. But we've got a vice president of operations, a vice president of clinical services, we've got a director of business development, director of safety, solely dedicated to our program, a director of government relations. We've got a manager of education, a manager of clinical services. Then we have 2 base managers. One really oversees operations and facilities. The other one oversees the clinical aspects. And then we have, let's see if I'm missing anybody, Director of IT that is helps oversee that area as well. So we really don't rely on services from our consortium at all. We're a freestanding organization from a financial standpoint and leadership and those types of things.
So it's completely separate then.
Correct.
Yeah.
Correct.
How does your strategic? Before I ask that, on your base, is there base managers too?
We have 2 base managers, but they oversee all of our bases.
Oh, that's what I mean. But
Yeah.
is there individuals at each base then too, like
No.
a base lead?
No,
Okay.
there's really not. No.
Okay. One of the subjects I'm always interested in is strategic planning. How does that? How do you all do strategic planning at LifeFlight Eagle, and who all is involved, and how often do you update your plan?
Sure. It's updated annually, and we typically convene in the fall, and it involves our full leadership team that I just mentioned, and also includes 2 outreach coordinators that we have that really are the pulse of what our customers are doing. And it also involves our medical director. So we convene once a year, and we start out by reviewing, our progress throughout the year from our current plan, and then we do a SWOT analysis. We validate our mission and vision. Is it still what we're about? Look at our strategies. Are we still focusing on the same things? And then we work on our initiatives for the next year. And that goes back to the board for approval. And if it's approved, then we communicate it out to the organization. And then every month we have a leadership meeting on Mondays, and it is broken up each Monday on one of our different areas. So one Monday it's marketing, business development, another Monday it's clinical, another Monday it's safety and government relations and those types of things. And so each leader in those Monday meetings goes over their strategic initiatives. So they stay in the forefront throughout the year. And, what progress are we making? Do we have any obstacles or barriers that we overcome? And so that way we're always continually focusing on the strategic plan and what we're working on throughout the year. So that's kind of how we progress.
That's excellent. I mean, that's the way to do it. I mean, I know a lot of organizations, do a strategic plan and put it up on the shelf and never do anything with it. And you've got to keep it front and center. And that's a great way to do it too, where you spending more focused time on each area rather than trying to, short brush things. So
you can lose sight of it very quickly.
Yeah. So was the board, I just wanted to make sure, is the board involved in the strategic planning, or are they just approving this?
They really approve it.
Okay.
Or the governance.
Okay. So your team is putting together the plan and what it should be. Got you.
Correct.
Is your medical directors involved with that?
She is. Our medical director is involved in that. Correct.
Okay. And talk about your medical direction. Is there one medical director, or do you have others that are involved?
We have one medical director and the medical control board, which consists of 4 other physicians. And it's 2 from each of our member hospitals, with emphasis in critical care and emergency medicine from both.
Okay.
Yeah.
I noticed on your website, a lot of organizations have, their values. LifeFlight Eagle has 5 key principles. What are those, and how did you come up with those?
It's really just kind of what drives everything that we do, and safety is at the core, as many programs. Everybody talks about safety, but it really is the core of everything we do. And from ensuring safe systems are in place to keep our crews and patients safe, empowering them to speak up, looking at potential risk, from everything to investing in the latest safety equipment, technology, partnering with our air operator on safety initiatives and training. So it's really, why we invested in a full-time safety director at LifeFlight Eagle as well. It's really just making sure everything we do, we're looking at it from a safety aspect. And so that really was why that's one of our key principles.
Mm-hmm.
And then employee engagement is one of our other ones. Our employees are what makes LifeFlight Eagle able to complete our mission. If we didn't have our employees there, it wouldn't be possible. So, we're continually working into how can we communicate with them better and engage them in what we're doing, and have them actively involved in our committees and helping us make decisions, because they're out doing the work and, providing the care that we do. So they're just key to our service and what we do for our communities. And then customers are the other big piece of that. If our customers weren't requesting our services, we wouldn't be here either and able to do what we do. So that's why we have 2 people committed to community outreach. And what are our customers needing from us, and are we fulfilling our promises to them? And that goes into the next key principle: do we deliver on our promises? And that just comes down to, do we do what we say we're going to do? And that's being an ethical company. And if somebody requests a helicopter and we say we're going to be there in 25 minutes, we're there in 25 minutes. If we say this is the type of care we provide, that's the type of care we provide. And that's really what has made us differentiated from other programs. That's been key to LifeFlight Eagle's success. And so it's just a major factor. And then that also drives into our public stewardship. We are a nonprofit organization, and we're more than just doing patient care. We provide hundreds of hours of community education and support each year to the local agencies, fire, hospitals. We attend community events, sponsorships, anything we can do to give back to our communities and be engaged in them. And that's really just what drives everything that we do.
Mm-hmm. That's great. You piqued my interest on the outreach coordinator. So are they out in the field most of the time, stopping in at referring agencies, hospitals?
That's exactly what they do. They go to the referring agencies, really just making rounds, if you will, touching base to see if there's any issues, or following up on flights, or, is there anything else we can do for you? It's really just keeping a pulse on what's going on out there and making sure that there aren't any issues, or that we're meeting the needs. And, did leadership change out there? Is there different things going on? And that's really the main purpose of it.
What is their background? Is it clinical?
It is clinical. One of them's a paramedic and one of them's a nurse, and they actually still do fly for us as well.
I see. So it's not full-time, but
correct.
Yeah.
They do, but they split it.
Yep. Yeah. I asked this because I've been interviewing a lot of the consortium programs. I'm always interested in whether you're operating with a break-even budget, or are you needing to be subsidized by your member hospitals?
We are not subsidized by our member hospitals. We never have been. We budget a small net income just as a cushion in case we've got a bad weather year, but we have never been subsidized and never needed to be from our member hospitals. So we've been fortunate. Yeah,
that's great. It's varying degrees, out there, and how the consortium programs are organized.
Yeah.
But let's talk about the locations of LifeFlight Eagle. I know you have a number of bases, and where your headquarters is.
We do, and I'll give you a little history of it as we go through it too. I think it helps paint the picture. But our base was originally at the downtown airport in Kansas City when it was formed. And the second base we opened was in 2000, and that was located at the airport in Harrisonville, Missouri. We're still there today, and that's about 40 miles south of Kansas City. And that was really just beginning to, move further out into the communities where the patients were. Being in downtown Kansas City really wasn't making a lot of sense, because you were just flying out somewhere and bringing the patients back into Kansas City. So it was really starting to evolve and getting your aircraft out into the communities where they were needed. So then our next base that we opened was in 2003, and that was out in Blue Springs, Missouri, which is really out east of Kansas City, about 20 miles. And then later that base moved a little further out, about 15 miles further out on I-70 to Odessa, Missouri. And that base was very interesting. It was actually a gentleman, we flew his father when we were based in Blue Springs, and they were landowners out there. And he wanted us to be further out in the rural area in the communities they lived in. And so he built us a base there, and he still is our landlord today at that base. So an incredible gentleman that built that for us. And then in 2005, we located an aircraft at the airport in Trenton, Missouri, which is about 100 miles northeast of Kansas City, up in the northeast part of the state. And unfortunately, that base is in a flood zone. So after about 2 floods and having to boat people out of that base,
oh my gosh,
that town was really not able to find another location for us. So just about 15 miles to the south, the city of Chillicothe offered to build us a new base at the airport there in 2017. And so we relocated there, still able to stay in the communities and serve them, just a little further to the south. So that's where we have an aircraft. And in 2007, we put an aircraft at the hospital in Clinton, Missouri. And that was another great community effort. The foundation of the hospital there in Clinton helped raise half of the funds for that location. And so we literally have a base sitting just across the parking lot from the emergency department there at that hospital, and have been there since 2007.
Does that include a hangar?
It does. All of these bases include hangars and full living quarters. And then our final base is still at the downtown airport, and that is dedicated to Children's Mercy. That's where they keep their aircraft that we manage for them.
I see. So that the children's helicopter is not kept at the hospital.
No, it is at the downtown airport.
Yeah. So let's talk about the aircraft, and if you give a little history too of the type of aircraft that were used over the years, and what do you currently operate?
Sure. The Spirit of St. Joseph LifeFlight, they actually had the Alouette 3s and then transitioned to the AS 350s. And Research Medical Center was in a Bell 206 helicopter. And when the program was formed, LifeFlight Eagle went into the BK 117 twin engine aircraft. And then LifeFlight Eagle eventually moved into Bell 407s, but they kept the BK 117 for children's flights.
I see.
And then eventually we moved the children's aircraft to a dedicated EC 145. So when they ended up needing their own dedicated aircraft, we purchased an EC 145 for them. And LifeFlight Eagle had 3 Bell 407s, and we eventually upgraded 2 of those to GXs. And now the children's aircraft, we ended up selling our EC 145, and they have moved into an F-76. So we've got 4 Bell 407s in our system and an S-76. So we leased one of the 407s and the S-76 from our air operator. We own the other 3.
So the S-76 is leased?
Yes.
Yeah.
Yes.
Is that the aircraft that they had chosen, that they wanted?
Yes, it is. Correct.
Okay. Yeah. So is there a difference? Does children's, again, there's no subsidy and you're paying for the S-76?
We have a contract to manage their aircraft. And so children's pays for the services.
Yes. Okay. That's
what we manage it for them.
Yeah.
Correct.
And the other bases are all under LifeFlight Eagle. You're just managing for the children. Yes.
Correct. They provide the medical team for their aircraft, though.
And how many aircraft do you own then?
We own 3 of them.
3 of them. Okay.
Yes.
Your current air operator, I know, is PHI.
Correct.
I know that they've not always been your provider. What other air operators had you used in the past?
Yeah, PHI has been our air operator since 2008. And prior to that, it was CJ Systems. And I believe right about the time we switched, they had been bought out by Air Methods.
Right. I remember that.
So, yeah.
Yeah.
So that was really I really couldn't tell you how long they had CJ Systems. I believe it was many years prior to the switch to PHI.
Yeah, I think that was an issue with the independent Air Methods program in town, right? The competition.
So. Yeah.
Have you ever looked at, with owning aircraft, developing your own Part 135? Is that something you've looked at, or?
It's been discussed and evaluated. And I think if we ever saw a need to expand and, add more aircraft and more bases, it would definitely be something we'd need to evaluate again. But it's just not been something that we felt was necessary for us at this time.
Yep.
But it comes up, when we evaluate and you expand your services, obviously. So.
Yeah, I know programs. It's funny. There's been some programs that have had their Part 135 and gone back, gone to an air operator. So it's interesting what you need.
Yeah.
Has LifeFlight Eagle ever had a fixed wing?
We've not had a fixed wing. And we've looked at that as well. In the Midwest and Kansas City area, it's really not been a high demand on the adult side. Now, Children's Mercy does have a fixed wing and a jet. They do provide quite a bit of transport for kids. And then there is a fixed wing service based in Kansas that does a lot of the western part of Kansas and down into Oklahoma, in that very rural parts of the state over there. But, Missouri's it's just not had a lot of need. Maybe once or twice a year, we may get a call if, that there's a need for a fixed wing or someone looking for somebody that does fixed wing. And so it's just not been one of those services that just seems to be necessary where we're located at right now.
Mm-hmm. And children's then, they must use a different air operator then for the fixed wing?
They actually do not. They contract directly with PHI themselves for their fixed wing and airplane.
Oh, I see. So PHI provides that.
Yep.
Interesting. Well, the other big area, and I've been following, other consortium programs too that have gone into critical care ground services.
Yeah.
Some actually even into more than critical care, but ALS, BLS, and wheelchair. But you've now have two critical care ground ambulances that you put into service in 2018 and 2019, I believe.
Yes.
Why did you start this service?
It was really to make sure we were reliable, and again, making sure we were being committed to our communities and delivering on our promises, because we were unable to fly during bad weather. And our communities, it left them with a gap when those patients really needed critical care. And, our crews were still on duty. They were still there and able to provide that service. They just couldn't fly. So we purchased an ambulance and put it in our southern service area. That was our first one. And so we put it into service when there's predicted bad weather. And our same medical crew that's on duty for the aircraft will then go on the ground unit. And then we were approached in our northern service area, actually by Chillicothe Fire Department, who provides the EMS service. And they'd recognized a need there when we were unable to fly due to weather and asked if we would partner with them. And so they provide the ambulance and the driver. And our medical crew goes on the ambulance with them when it's bad weather and we're not able to fly.
So your ground services are strictly when you're down for weather on air.
That's correct. And that's right now. But really, it's been I think it's something that's going to expand. It's really I think it's going to be a necessary service as things continue to evolve in critical care transport, and the need is there. So I really believe we're going to see that continue to expand, but it's really been a much needed service for our areas.
Well, I like the way you're doing that. And I know in looking at that in the past, the problem with ground is reimbursement.
Right.
Usually. And when you have full-time programs, it's pretty hard to make that work financially, where covering for the air, you're providing the service to the patients.
Right.
Do you still have some issues with getting reimbursed for those transports though?
Yes, there's no charge typically for critical care. The highest you can bill is specialty care.
Specialty, yeah.
And some of them are really going to only be classified as ALS trip. And so you're not going to make a bunch of money off of it. That's just for sure. But still the right thing to do for the patients, because that's the level of care they need. And that's really been our focus all along is, what's the right thing for the patients? And if that's the level of care they need, in some of our rural communities, it isn't available any other way except by our medical team.
So how do you make that? This was quandary I always wondered about too. Is how you make the decision? Because weather. I'm originally from Michigan. We used to say, wait 5 minutes. I think Minnesota has probably every state has that. Maybe not Texas right now, but how do you make the decision that, we need to go by ground and then perhaps miss 2 or 3 flights because you're, on the ground?
Well, we try to predict best we can. We look out 24 hours in advance, 48 hours in advance. And if we see forecasted weather that we believe is going to prohibit us from flying, we will activate the unit. We have drivers that are on call.
Yeah.
And, we may cancel it if the weather doesn't forecast, end up being what it's supposed to be. And we typically try to look if it's going to be forecasted weather for longer than 6 hours. If it looks like it's only going to be weather for a couple of hours, we don't activate the unit, because if you take a ground trip, it's going to take you probably 4 to 6 hours just to turn it around.
Yep.
And again, you could be flyable by then. So that's really kind of how we've set some of the parameters in place. And you predict the best you can. And it's just that weather's not always predictable, but that's just how we've tried to do it.
That makes a lot of sense.
Yeah.
One of the questions I had, because I didn't realize how you were doing the ground, is, is it the same clinical capabilities? So you've got basically it's the same staff. So you're doing all the same types of transports then too.
We are, correct.
Talk about that. Talk about your clinical staff, what mix you have, and then also their capabilities, types of transports you're doing, any specialty equipment or specialty teams that you might use.
We've been CAMES accredited since 2001. And, it's always been our goal to exceed any of the standards that we've had in place. And our clinical teams, they're trained for adult and pediatric scene and interfacility transport. And then they do pediatric scene transports. Children's Mercy handles most of the interfacility pediatric, and then they do all the neonatal. So our teams don't do neonatal transports. The
I see.
specialty is handled by Children's Mercy on that side. And then our medical teams are all required to have 5 years of experience, either in an ER, critical care, or a busy ALS unit before they ever even apply for LifeFlight Eagle. So we've kind of set that higher standard as well before they even come to work for us. And then within 2 years of hire, we require them to have their advanced certifications for flight RN, flight paramedic certifications, and those types of things. But they can do, any diagnosis, all scopes of care. We do not do any type of ECMO or those types of things. And that's really the limitations of our aircraft, to be honest with you. The cabin size and those types of things.
Mm-hmm.
We could move into that into our ground units if we start doing more of the ground type of transports. And that's something that we continually evaluate also.
Have you had a lot of demand for that? Seems like that's
We do
going
get
up.
more and more requests for that. Absolutely. Yeah.
Is that a limitation of the 407?
It would be a challenge to get that equipment in there.
Yeah.
It's just, it's a challenge. It would be a challenge to put some of that equipment in that aircraft.
Yeah. Any other, any specialty teams that get on the aircraft with you?
No.
And then on the Children's Mercy, they have their own team, correct? Is that a RN respiratory?
Theirs is an RN, a paramedic, and a respiratory therapist. Correct.
I see. So
an RN, a respiratory therapist, and an EMT. I apologize.
EMT. Okay.
Yes.
And do they? LifeFlight Eagle doesn't provide any of the staff for that, even for backup.
No.
What happens when children's aircraft is down? Do you provide backup then?
We do not, because they have a fixed wing, a jet, and multiple ground units.
I see.
So they have their own multi-mode system that provides all their own coverage.
So they can go by ground. Okay.
Correct.
So how many total employees do you have, and how many are provided by PHI?
We have 64 LifeFlight Eagle that are medical team and communication specialists.
Mm-hmm.
And then PHI provides 33 for the pilots and mechanics. So, it's a little over 100, about 100 total between the two of them. And we staff with our nurses and paramedics is what our medical team makeup are.
You had mentioned under your community stewardship services earlier, you were calling it outreach. Talk a little bit more specifically on what type of education you're offering, the fire departments, EMS agencies, and hospitals.
It's a broad gamut of classes, but it really, we've seen it expand so much over the years as education funding has been cut, I think, in a lot of areas, and just the ability for them to go get education, whether it be they can't travel to it or they don't have the time. And so we've provided on average about 48 American Heart Association classes each year, 25 to 30 specialty classes, whether that be around airway management, ventilator management, sepsis, time critical diagnosis, mock drills that we do with the hospitals, the time critical diagnosis classes.
What type of mock drills?
Those will be like the stroke STEMI patients.
Okay.
We'll actually do those with the rural hospitals, to make sure we're getting the timing correctly to get them to the receiving facilities.
I see.
We do about 35 safety and landing zone type trainings with the different agencies and the hospitals throughout the year. Participate in anywhere from 45 to 50 different health fairs, events, community speaking engagements, and those types of things throughout the years. And then we launched a philanthropy campaign a couple of years ago to raise funds to eventually be able to have a mobile simulation lab that we're able to actually take out into the communities, so we can just take that more advanced education and training into the rural areas that they're not able to get themselves. So anything we can do to help provide education to them, and so they're able to provide a higher level of care to their communities, is really what our ultimate goal is.
And I'm sure that's much appreciated.
It is.
And is that your clinical staff then that's doing a lot of the teaching?
It is all, yes,
Yep.
it is. Yeah.
I notice you have a membership program. If you could talk about that program, and does that cover both air and ground?
Sure. It does cover both air and ground. And really it was driven out of this aspect of, we're in a rural area where there are a lot of patients may not have insurance, or they don't have coverage that'll coverage an entire bill, or they have high deductibles or copays. So we're looking at a way to help our communities again. If they have to be flown, how do we help offset some of that for them? So the membership program was put into place, I want to say 2005 timeframe. And at the same time, we also started looking at how can we be getting provider agreements with insurance companies. So it's kind of a two-pronged approach in the network agreements. But the membership program costs $59 a year for a household. So it covers anyone that lives in the household. And if they're flown, we bill any insurance they have, and we accept whatever payment we get, and then we write off the rest of it. So there's no balance bill. They don't have any copay, deductibles, or any cost. And if they don't have insurance at all, the entire bill's written off. They never receive a bill at all. And so it's just been a phenomenal thing for our rural communities. The testimonials from patients, it's life-changing for them if they have to be flown and not receive any out-of-pocket expenses for them. You know, and even Medicare patients, I know there's a debate about whether Medicaid patients need it, but a lot of these patients are Medicare Part B. They have no other supplemental, and they're going to have a 20% copay. A 20% copay on an air medical flight, it's not an inexpensive charge. You know, it's a few $1,000s, and a lot of them don't have a few $1,000s to come up with. So it saves them that expense. $59 is much more reasonable for them. And then we were also very fortunate to be able to get a network agreement with Blue Cross and Blue Shield of Kansas City well over 20 years ago. We probably got one of the longest standing network agreements that's out there for air medical. And we targeted them initially because they are one of our, they covered one of our largest insured populations that we flew. And since that time, we've secured 4 network agreements with insurance companies. And so we've done anything we can do to try to offset balance billing, you know, which is a big debate in the industry right now. And so between our membership program and our network agreements, we've really narrowed that down and limited any balance billing that would occur from our program. And so it's really important to us to try to continue that efforts.
So you actually, I know some membership programs will not sell the membership if they don't have insurance. So you would actually sell a member to someone that doesn't have insurance at all.
Absolutely. The only ones we will not sell it to is Medicaid patients,
right?
Because there is no need. You know, they don't have out-of-pocket expenses, so it's actually not legal to sell to Medicaid patients. You shouldn't. So,
right. Exactly. Does the program? Is there a reciprocal agreement with other programs on your membership?
There's not, and that's a state issue. Every state different regulates that. The state of Missouri actually does not allow reciprocity.
I see.
And we wish they did, because we have a very large amount of air medical programs in our state, a lot of cross coverage, and it is a challenge for community members that buy memberships. And so we tell any people that are buying memberships, if you live in this area, there's another air medical program right here, and it's especially in the Lake of the Ozarks area. We encourage them to buy both memberships, because you don't know which air medical program is going to respond. You know, if we're out on a trip, they're going to call the other one and vice versa.
Right.
So, you know, spend $120 for 2 of them and be covered by both, because it's really, that's the situation we're in, because the state does not allow us to reciprocate each other's programs.
What about Kansas?
Kansas does not. I'm not sure if they allow it or not, to be honest with you. And we just don't have that many over there from a cross coverage standpoint. So
I see. But you cover, I mean,
we can go into Kansas a little bit, into a section of Kansas. Yes.
Yeah. Talk about what you're doing on the government relations side on both the federal and state level. Do you have your own government relations staff or people that work on it, or you coordinate with your consortium members?
Sure. We actually have a full-time director of government relations, and that's Ruby Mayer. Most people know Ruby throughout the country.
Ruby.
Everybody does.
Everybody does. Yeah.
Yeah. Ruby's been with our program since it was formed, and prior to that, she was at Research Eagle. So which is just a huge asset to us because Ruby is known throughout the state and honestly the nation in the air medical industry. So she sits on a lot of our local committees and has been involved at the state level in roles, in leadership roles. And so she's very actively involved in government relations and what's going on and keeping a pulse on things. And she's also been actively involved in the Association of Critical Care Transport,
Right.
and just keeping engaged in those activities. And so at the state level, I could just name a litany of things she's been involved in, but time critical diagnosis and regulations around those at our state level, anything that's come up around balanced billing, when things have come up around those, different things come up around membership programs at different times. So Ruby's always keeping a pulse on those things for us and, making sure our medical's represented and at the table. That's really the biggest piece that she does for us. So we're fortunate around that. And we do engage our consortium lobbyists and those types of things from the hospitals when things are going to impact them or could, or that we need support. And all of us kind of have a single voice, if you will. So
yeah, because balanced billing really affected the hospitals too.
It did,
in a big
correct.
way. Yeah.
Yeah. So we do join hands, if you will, when we need to on those types of things. So
Yeah. Do you think the balanced billing is going to affect the membership programs? I know, North Dakota passed a law not to allow membership programs. Do you think that's going to be pressure on that?
the way it's written today, it does not appear it will impact the way we're currently functioning with our membership program. There's current legislation in Missouri that's trying to impact membership programs today, and it's not trying to prevent you from doing it, but wanting them to be regulated as an insurance product. So there's always something going on that's trying to change the way that they function, and some of that really just comes down to how you're administering your membership programs. Are you administering them ethically in the way they should be administered in the first place? And so I think as long as you're doing them the right way, I think we should be able to continue to offer them. So that's my goal anyway.
I know Air Methods has had a big campaign against membership programs. Has that affected you in your area with people asking?
Yes, people are asking because of the campaigns going on, but it's not had much of an impact of people not pursuing and continuing to keep their memberships.
Yeah. Well, the big thing this past year and now into this year has been COVID-19.
Yeah.
How has that impacted your operations, and what extra precautions are you taking with that, and how has your transport volume been affected?
Our volume was really impacted early on. So, last March and through probably May, we saw 35% decline in volume. That was really about the period of time when the country shut down. And I think, we were fortunate. I know other programs saw a much greater decline in volume. But really, when the country opened back up, we saw our volume come right back to normal. So we've continued to see our volume stay steady and consistent throughout that time. We have seen our number of COVID transports increase and continue to, as the pandemic increased and things got worse throughout the fall and winter months. But, a lot of extra precautions similar to what other programs throughout the country have had to do. Our staff have had to wear much greater amount of PPE and ensure their, precautions that they're taking and decontaminations of the aircraft. And they treat every patient that they transport as if they have COVID, because you don't know. You have to. You have to. And, they have special respirator masks that they wear if they do know they're COVID. And it's really changed how they practice medicine, if you will, and put a lot of extra, I don't call it burden, because it is just part of what they do, but it really is a different environment now, and a different, lot of different things that they have to do, wearing masks at the base when they're there all day long. And just, the cost of the supplies and everything that we're having to purchase to do this as well. It's really impacted a lot of things we do, but they've all done a phenomenal job this entire year of keeping us in service and doing what needed to be done. And so very proud of all of them. They've just done an outstanding job. Have you had supply issues with some of the? We did early on. We've got our base manager, Chuck, that manages our supplies just has done an outstanding job. He's on it. He would go to all great lengths to get supplies from where he could get them from, and we were even able to help some of our fellow colleagues out throughout the country and when they couldn't get supplies and things. But it was a challenge. You really had to look through, any vendor that you could get them through, but and the cost, then you were paying out exorbitant cost a lot of times. So it's gotten better. There's still some things that are, backlogged and things you can't get at times, but he's just done an amazing job in keeping us stocked in what we needed to get. So,
yeah, I think your experience from what in talking to other programs, it's very similar. That March, April time period, flights down, people not knowing what's going to be happening, and then I think with the rural hospitals not having the ICU capacity that necessitated moving patients, COVID patients, into the urban hospitals. So that's very similar. And it's, we've always had to use universal precautions, but I think this has really put a big light on that. And
whole different
probably,
level.
Yeah, and we'll change that probably now and into the future too, and how we look at that.
I agree.
Yeah. I know LifeFlight Eagle is a member of ACCT, and we'll talk about that. But are you a member of AIMS too, or had you been a member of AIMS?
We had been, but we have not been for several years.
Okay.
Just our staff really weren't, a big reason we had been a member of AIMS, they were attending AMTC education events, and the staff really just weren't getting a lot of value out of that over the past several years. They were attending other conferences and finding more value in it. And so we ended our membership several years ago for that reason.
Is that something that you'd reconsider if things changed with AIMS?
Always evaluating what's out there. Yeah, absolutely.
Yeah. You have been on the executive director now and a board member of ACCT since December 2014, when I believe that's when Fitch Associates took over the management contract.
Correct.
For ACCT. Talk a little bit about ACCT, some of the history, what the association is working on, and full disclosure, I was on the helped out ACCT early on, actually, with the website. I think I worked on, and then was a board member too. So
yeah, absolutely. ACCT's a nonprofit patient advocacy association, and it's made up of members that include critical care transport programs throughout the nation, and actually one in Canada. And we also have member organizations that provide supplies and equipment and types of things from that support our industry. So whether that be air operators, helicopter manufacturers, equipment manufacturers, we have insurance brokers, those types of things on our, and other associations are part of our association. But our focus is really, driven around several different things. One of them is just the critical care, highest quality and safety that we can provide. So one of the big things that has been a great thing I'm proud of is the critical care standards that they created. And I think they're on version 2 now. I think you'd mentioned as well.
Yes.
And the second version actually included the medical control aspect of it and the quality metrics. And they've been working hand in hand with Gamut in the metrics and ensuring we've got critical care metrics as part of the Gamut database. And now the focus is on benchmarking, and not only internally with ACCT members, but externally, and really looking at how we compare and what we can do to help improve upon those things. So that's Jeff Stearns is doing great work with that out of Mayo. He's the chair of that, and Chuck Hogan from LifeFlight in Maine. So they're doing an incredible job on that project. And then really leadership development has been another huge focus of ACCT. And we put on 2 conferences a year, and unfortunately with COVID, we weren't able to do that last year, but our next conference will be in October in San Antonio. And that's really been around kind of filling a gap that we felt was there around executive level leadership training, and bringing in quality speakers and just really providing that education to the executive level leaders in the organizations. And that's been an outstanding project, and I feel benefit to our members throughout the years. I think that's been probably 6-7 years now that they've been doing that as well. And then the patient advocacy, or just advocacy in general work that we do in DC. and trying to push legislation that brings a standard of care to the industry and a standard of care around quality, safety, cost reporting, just the whole gamut of things. And that really kind of ties back into our critical care standards. So that's a lot of the work that we've been working on in ACT.
I see. Yeah, I want to take a couple of those. I really thought the critical care standards I thought were excellent. I know when the first volume, I bought up a bunch of extra copies and gave them out to people because I was thought that they really hit the mark. And it's very interesting what you're saying that you're doing with the second version. So are those not out yet, or is
the second version is out? It's digital. We didn't reprint the second version because we keep modifying, and so it seemed not cost effective to keep printing them when you're modifying them. So it's a digital version.
And so those are updated continuously then?
Correct.
And
but the digital version is available on our website for the members.
So that's where people can get them.
Correct.
Can a non-member
they can purchase the digital version on the website. Yep.
When you talk about the advocacy, let's talk specifically on the balanced billing legislation. I know that was a lot, and that legislation is now passed, and we go into the rulemaking phase. What's ACT's position?
ACT is very pleased with the balanced billing legislation. They actually had been pushing for everything that was in the legislation that came out, and we're really pleased to see the different things that came out in regards to the quality standards and looking at the different levels of care and cost reporting. And so, now we're looking at to the rulemaking and the advisory committee that they're going to be forming to help start setting some of those rules. And so we're pleased to see that. There's still a lot of work that has to be done before that goes into effect, but I think it's a step in the right direction for our industry for sure.
Yeah, I think the devil's really going to be in the details.
Absolutely.
Stuff.
Yes.
Is ACT, do you know how people get a position on the rulemaking? Is ACT have a position, or?
They have not sent out call for nominations for that yet, but I'm sure it'll be like any of the other ones. You have to submit nominations and they choose at the federal level.
Yeah, I hadn't heard anything either.
Yeah.
So do you see working with Ames on some of that, or on areas that you agree on, or?
Possibly, we've tried in the past. We've all convened and worked on separate pieces that we've agreed upon. We attempted on the billing pieces as well. There's just always seems to be some segments of it that we just don't quite come to consensus on. Mm-hmm. But absolutely, if there's areas of that we can work together on, I think that's always a good thing for our industry.
Yeah, I do too. As you know, I've always said that even when I was on the ACT board, and I full disclosure on the Ames board now, and say the same thing. So I guess I hearken back to the days when we were all under one roof. In January 2019, you were named as a partner with Fitch Associates. Congratulations. So what this sounds like even more work.
It tends to be, but I had, I've already been part of their company with serving in management roles for ACT and LifeFlight Eagle. And so this is just kind of an evolution as serving as a partner in the firm and helping with some of the consulting projects and with the management side in the main office there in Platte City. So it's just, I look at it as development opportunities, and I absolutely love working with all of them. It's just been an incredible opportunity. So I don't view it as more work. It may sound like that, but it's just a great opportunity for me. So I relish it. I love doing it. So.
Well, you absolutely amaze me with the things that you do, because I think, just running an association isn't a job, and then plus a large air medical program, and now being a partner.
Do it without all the people around me. So thank you.
Well, I know it's always a team effort for sure, but you have a lot of hats. The other one that, and I think I always sent you emails like, well, Roxanne, where do you find the time to do this? Is all your publications. So talk about some of the things that you've authored.
Yeah, Fitch partners with actually EMS One and to publish articles really geared towards EMS leadership, and they also do the chief concerns for fire service related articles. And so our Fitch leadership team, every year we kind of split up topics that we're experts in or have, knowledge
Interest,
in.
yeah.
We write articles. So that's kind of our goals every year. I at least write one. Jay and some of them write a lot more articles than I do. So, that's more of their expertise. But I've written several just around things that I have passion about, or just things. I've written one on membership and nonprofit organizations and critical EMS leadership traits, just varying different things over the years that I felt like I could at least add some, depth or knowledge to from my experiences. So it's fun.
I remember doing it. How can people get a hold of those? I was searching for them. Is it on the Fitch site, or is it?
They are on the Fitch site, I believe, as well. But EMS.1 also keeps them in their leadership site of that also. And I can get you that information specifically where they're at on there. I just don't have it off the top of my head.
If you could send me the link, I'll put it in the show notes.
Sure will.
So people, because I think people should take a look at those. I was always.
But they do archive them all, so they're all there.
I was just, because there were great articles, but I'm like shaking my head, like, how do you have the time to be doing this? So that's fantastic. So let's move a little bit more on the personal side. I know that you were recently married within the last year. Congratulations on that. And it was been fun following you on Facebook. So who's the lucky man, and how did you guys meet?
Yeah, I married Scott Peak, and we've actually known each other most of our lives. We grew up together, went to school together, grew up in church together. So our families have known each other most of our lives. We just met and married other people out of high school, and then ended up running into each other several years ago, and ended up started dating and ended up getting married. So kind of came back together, if you will. So
that's fantastic. So you didn't date in high school necessarily.
No, we're just good friends. So
good friends. Yeah. How big was your high school?
About 500 people, maybe. No, probably more than that. A couple hundred each class, maybe 800. Probably 800.
Okay.
Yeah.
And you grew up in what town?
Savannah, Missouri. So it's about an hour north of Kansas City.
I see.
And
that's right near St. Joe then? Or?
It is, just north of St. Joe. Yes.
Yeah. And you have children, right, from prior marriage? Yeah.
Yes, I have a son, Brett, who will be 21 in about a month, and he is finishing up nursing school. He will be done. He will graduate with his BSN in December.
Excellent.
So so that's exciting. And then I now have 3 stepchildren. One of them is 23. And Jessica she has a marketing degree and works in Kansas City with a large radio network. And Connor is a senior in high school, and so he'll be going off to college. And then Logan is our 8-year-old little Spitfire who just is young or exhausted all the time. We haven't really looked at it, but yes. So we've got the gamut. So.
Oh wow, you do.
Yeah. We do. It's fun.
And I said, how do you have time for all that? Yes, okay. I won't, no more comments.
Exactly.
Oh, geez. Yeah. Makes it fun. So what do you guys like to do for fun?
Oh, we love to travel. When I have time to travel outside of work, love to travel and go to new places. And then when we're home, we have a pool, and the kids absolutely love to swim. They bring all their friends over. We cook out and just chill by the pool. We absolutely love to do that. So that's our idea of a good time.
Has COVID kind of put a damper on some of that? I know travel
put a damper on travel completely. Yeah. So that's been kind of a bummer, but we spent a lot more time in the pool last year because of COVID. So it kind of did that. So we love doing projects. So we're always working on something. So it's good.
That's great. So anything else that I might have forgotten to ask you on questions on the podcast? Anything about LifeFlight
Not that
Eagle?
I can think of. I greatly appreciate you having me today, though, and let me kind of share about my life and everything that I do, and all the great people that are helping run all these organizations with me. So
you've got good teams, and that's it's what it takes. But it takes leadership too, and I think you're a great example of providing leadership, and that's why I like to do these podcasts, because I want people to understand how different programs are organized, but also the people behind it and how they've come into being. When I started this in 2009, it was the movement to a lot of people were going over to the for-profit side. And I wanted people to understand where people were coming from, and because we sort of created this divide, and I like people to, understand more that we're a lot more alike than we think. So.
Yeah.
So, Roxanne, thanks so much. I know
Thank you, Edward.
I don't know how you had time to even be on this podcast, but
well, it took me a few months to get with you. But
that's true. That's true. But I kept after you. But so thanks again for being on the podcast. We really appreciate you sharing everything. So
I appreciate you having me. Thank you very much.
Thank you. Thanks for listening to this episode of the Air Medical Today podcast. Please come back again and also subscribe to future shows by visiting the website at airmedtoday.com, iTunes, or on the Air Medical Today YouTube channel. Air Medical Today is also on Facebook, Twitter, and LinkedIn. You can find the links on the website. Remember, if you would like to become a sponsor or provide feedback, please write to webmaster@airmedtoday.com or call 612-367-6052. A very special thanks to Stanley Reeves of Room Tunes for providing his song, Track 5, for use as the theme song for the podcast. You can follow Stan on Facebook at facebook.com/stanley.reeves.39. Take care and fly safe.